Hello and welcome to another Pipe of Pearl. Today's Pearl, we're going to be looking at the Weber and Rinne test. Now these tests have been around for a long time. The Rinne test in particular was first proposed in the mid-1800s and then really fine-tuned in the 1900s and then named after Rinne himself. Now this test is used to indicate the difference between conductive versus sensorineural deafness. Now, it's not a definitive diagnosis. It is a very common test or two tests that are used by ENTs, GPs, in order to give us an understanding of whether or not we're dealing with a conductive problem or a sensorineural problem. From there, particularly if it's a sensorineural problem, you go on to further testing and further investigation. If it denotes that it's conductive deafness, then you have a look in the ear and try to determine why it's conductive deafness. Before we get to the tests themselves and have a closer look at the two different types of deafness that you can get, we'll just have a quick review of the anatomy of the ear. So it helps explain why the Weber and the Rinne test can work and then certain findings themselves. So having a look at the ear anatomy itself, you know that it's broken up to the outer ear, the middle ear, and then the inner ear itself. Now the outer ear, as far as hearing is concerned, is purely a channel that fine-tunes all the vibration around you as it travels through the air, coming down before it finally hits the tympanic membrane. The tympanic membrane is like a drum. When the sound waves hit it, it starts to vibrate. This in turn will vibrate the ossicles that are resting upon it. Now it's the vibration of these ossicles in the middle ear, which is an air-filled chamber, that creates its own internal vibrations within the ear itself. And these vibrations are fine-tuned down the oval window into the inner ear, which is the vestibular cochlea. Now when we're dealing with hearing itself, we're interested in the cochlea, because the vibration that has come from the ossicles will then pass through the endolymph all the way down the cochlea until it reaches a point that the vibrations will no longer travel down the endolymph, but actually hit the center component of the cochlea, which will start an action potential, and then the information will be sent to the brain. So as you can tell from there, we have two different aspects that are working. We have the vibration of the ossicles, and then we also have the sending of the signal from the cochlea to the brain. So when we're dealing with conductive deafness, it obviously means that the ossicles themselves can't be vibrated. If you're dealing with sensorineural deafness, it means that the vibration from the ossicles can't be passed on, or the message itself can't be passed on to the brain. Now, in the absence of sound waves, if we found a way to vibrate the ossicles themselves, or even vibrate the skull around it, that same vibration through the bone can be passed on to the cochlea in order to denote hearing, or some sensation of hearing itself. And that's basically what the Weber and Rinne tests will actually be looking at. So when we look at the causes of hearing loss, as mentioned, we have the sensorineural and we have the conduction. The sensorineural, as you can see, they're all your normal ones. Well, they're the ones that have caused damage that are outside of any foreign body. Okay, so you're getting older, things are slowing down, too much noise is itself, basically, you've worn down the ossicles, is the result of too much noise. Side effects from drugs, especially your ototoxic drugs themselves, tumours, and blast trauma. They're your main causes of sensorineural hearing loss. And then you move over the side of conductive hearing loss, and they're a little bit easier to understand. They are physical things that stop the passing of vibration from the external environment into the middle ear. So fluid, foreign body, wax, allergies. And then obviously you have the good old, the eardrum no longer vibrates because it's ruptured. So that's kind of obvious too. Now infection sits in the middle, because you can have an infection of the middle ear, or you can have an infection of the cochlea, or the brain itself. Okay, so infection is both ways. Infection mostly causes conductive hearing loss itself, like otitis media, for example. Okay, let's have a look at the tests themselves. So the tests, as mentioned, are two different tests. You've got the Weber and then you've got the Rinne's test. Always do the Weber test first. Okay, it's a good indication of having an overall picture of whether or not which one's the good ear, which one's the bad ear, which one's conductive, which one's sensorineural, that sort of thing. Now, every clinician should have a tuning fork that's 512 hertz. Okay, it's a great little tool to carry around. It has a number of applications. This is one of them. It can also be used to detect fractures as well. Obviously, small ones. If it's a big one, you can use your clinical signs. Okay, so they are very, very useful tools. Now, the Weber test is designed to basically just use a tuning fork and place it in the center of the head and then ask the patient questions. So before you do the test, you ask the patient if they have an ear that is experiencing more deafness than the other. Okay, you can precede this one with a finger rub test or whispering test, which is part of like the normal cranial nerve assessment to see if there's any differentiation between the ears, or you can ask the patient which one's the good ear, which one's the bad ear. Okay. Then the Weber test is as simple as striking the tuning fork, so creating the vibration, and then placing it in the center of the patient's forehead, and then just waiting and asking the patient which side they hear the tuning fork better. That's it. Okay, so what's happening with the Weber test is two things. You have the vibration sound that's happening from a cone from the tip of the actual tuning fork around that the patient can technically hear. Okay, and then you also have the vibration of the patient's skull that is being passed down through the actual middle ear into the ossicles or into the cochlea itself. So the actual vibration of the skull is causing a sensation of hearing as well. So if the person has normal hearing, they won't be able to say it's louder on either side. It will just be the same sound on either side. Now, if the patient has indicated that they have a bad ear, in this case the right ear like it is in the picture, and you do the Weber's test, but they say the sound is better in that right ear, so the worst ear can actually hear it better, then that's indicative of conductive deafness. The reason for that is they're used to hearing things through sound waves, and therefore the sound's not getting through because of a conductive problem. And the tuning fork itself is not being heard around the outside, so it's basically no sound waves are getting in. But the vibration of the skull is bypassing the ear canal and therefore creating sound within the middle ear and the cochlea where there is no problem. So it is louder on the conductive side. If the patient says that it's louder on the unaffected side, then that indicates that the right ear is more likely suffering from sensorineural problem, because even with the direct vibration of the Weber's test, bypassing the ear canal and vibrating the cochlea and the ossicles themselves, it's still not providing any sensation of sound. So that's the first test. From the Weber's test, you can move on to the Rinne's test. Now, this is a test where you'll actually test each ear. So it's best to start with the worst ear, because you've already got an indication of whether it's conductive or sensory when you've done the Weber test, and this is basically a confirmatory. So the way you do a Rinne's test is again with the 512 hertz tuning fork. You flick that in order to create a vibration, and then you place it on the back of the mastoid. So behind the ear, you'll find a bone, and you place the base of the tuning fork on the bone, which will obviously directly pass a current or a vibration through that bone to the cochlea itself, causing the vibration of the cochlea. Once the patient can no longer hear or have the sensation of hearing from the direct or bone current that is occurring, then you rotate the tuning fork around, because it's still vibrating, and place it in front of the ear and ask the patient to indicate when they stop hearing that. Now what should happen normally is air current should be better than bone current, because that's the way it's designed. There's less obstacles to pass through. If there's nothing wrong, then the air will pass straight through from the tuning fork and you'll be able to hear it, and you'll be able to hear it for longer, and it'll be a much higher pitch. Okay, now if the patient says that they can hear the air current, then obviously that means there's no obstruction. But if there is an obstruction, then the air current can't get through, and the patient will actually indicate that the bone current was better than the air current. Okay, so placing on the back of the mastoid was actually better, clearer, louder, longer than putting it in front of the ear itself. And because that was a lot to go through, we'll just summarize the findings so then you can sort of have an idea of whether or not it's sensorineural or conductive, or if the patient is normal. So if the person has normal hearing, if you're doing this on someone that doesn't have any hearing problems, like if you want to train this and practice it on each other, then what you'll find is you'll do the Weber's test and it'll be the same both sides. The Rinne's test, it'll be normal, meaning it'll be normal to have air louder than bone. Okay, so that's it. If you have a sensorineural problem, you'll say that it is louder in the unaffected ear. Okay, because there's nothing wrong with that ear, it's vibrating it. But the affected ear can't actually get any messages passed on through the bone itself. Now, sensorineural can be difficult with the Rinne's test because they can say that air is louder than bone in the unaffected ear. They can say it in the affected ear as well, but they can also say that air and bone both don't provoke any sensation of hearing. Okay, so air and bone don't. Because even if the ossicles are vibrating, once they get to the cochlea, there's something wrong with the cochlea, which means there's no sensation of hearing. Or if they've bypassed the ossicles themselves and they're vibrating the cochlea itself, there's still something wrong with the cochlea, therefore there's no hearing. Okay, so sensorineural is obviously the most difficult and obviously requires the most extra investigations. If you have a conductive problem, you'll find that Weber's test will be loudest on the affective ear, and bone will actually be preferred over air. So you'll be able to hear things longer through bone conduction than you will through air conduction with the Rinne's test. Okay, so that finishes the Weber's and Rinne's test. I hope you got something out of it. From here, if you don't have a tuning fork, get yourself one. They're a great tool, great diagnostic kit that you can carry around. And practice on people. Okay, practice on individuals. Just remember that if you are getting a tuning fork, the best one for us is 512 Hertz. Any lower than that, it's mostly used for specialized vibrations, and it can be a little bit too loud to put close to someone's ear. So 512 is your aim mark. Grab one, practice it, get comfortable, and remember that the Weber and the Rinne's test are both used as an indication to invite further investigation, either by yourself having a look in the ear to see what sort of conductive problem we have, or referring the patient on to more sensitive testing to find out what the sensorineural problem is. But until next time, take care.